started, I want to welcome you today to the Research Brown Bag, an event sponsored by the Nursing Center of Excellence. Today we have Dr. Laura Opton and Dr. Amy Moore, who will be presenting their work, Partnership to Reduce Cervical Cancer Risk in Nicaragua. Thank you. Oh, that was hard to say. Dr. Moore is an associate professor and director of the Global Health at Texas Tech University Health Sciences Center. Is that correct? Okay. She also serves as a consultant for the ATI, which is the Assessment Technologies. I'm just going to say ATI. There you go. Thank you. Nursing Education Board. Her previous positions have been in academia. She was an assistant professor, clinical site coordinator at Texas Tech University Health Sciences Center. She's been an instructor at Tech and a family nurse practitioner at the health clinic in Wolford. Dr. Moore is certified as a paramedic, a BLS instructor, a family nurse practitioner, advanced life support, and is certified in the CITI, which is the Collaborative Institutional Training Institute course in the protection of human research subjects. Dr. Moore holds professional memberships in the American Nurses Association, Sigma Theta Tau International Honor Society, American Cancer Society, Quality of Life Association, the South Plains Nurse Practitioner Association, and the Texas Nurse Association. Dr. Moore is a nurse researcher and has published her work in various nursing journals. Additionally, Dr. Moore has delivered many professional presentations as well as poster presentations. Dr. Moore received her Associate in Nursing from Western Oklahoma State College, her Bachelor's from West Texas A&M, her Master's degree with her family practitioner from West Texas A&M, and her Doctorate in Nursing Practice from Colorado University in 2012. Dr. Opton is an Assistant Professor and Program Director for the second degree BSN Nursing Program at Texas Tech Health University Center. Dr. Opton has also been an instructor and coordinator for the second degree BSN program and faculty associate in the traditional undergraduate program and director of student affairs in the undergraduate program. Dr. Opton began her nursing career by serving as a staff nurse at Covenant Health System back in the 90s. Dr. Opton holds certifications in nursing education as well as the CITI, the Collaborative Institutional Training Institute. Dr. Opton has honors too numerous to mention and is a nurse researcher and has published her work in numerous peer-reviewed nursing education journals as well as poster presentations. Dr. Opton serves on various professional organizations and is a volunteer with the American Cancer Society, the Children's Home of Lubbock, the Community Health Center, Community Care Ministry of Lubbock, Monterey Children's and Teen Ministry, I don't know when you sleep, either one of you, Camp Nurse for Pine Springs Summer Camp, and sits on the School Health Advisory Council for Lubbock. Dr. Opton received her Bachelor of Science in Nursing from Texas Tech Health Sciences Center, her Master's of Science in Nursing from Lubbock Christian University, and just this year earned her doctorate in Health Sciences from Nova Southeastern University in Fort Lauderdale, Florida. I'm glad you both are here. And then our invited response today will be delivered by Dr. Linnell Harrison. Dr. Harrison is the current director of the BSN program at LCU and earned her PhD from Texas Women's University. So I want to make sure everyone got signed in and be sure you pick up your certificate out in the front if you want your certificate. And I'm part of the Alumni Association. I'm a graduate of both. Got my bachelor's here and my master's in 2011. And so we hope that when those of you who are here and you graduate, that you'll be active members of the Alumni Association. So welcome.
Thank you to the Department of Nursing here at Lubbock Christian and to Dr. Long for inviting us to speak. Amy and I have a real passion for global health and women's health, so we're really excited to be here and to share with you some of the work that we've been doing in Nicaragua with our students and our faculty in the Women's Health Initiative. So Thank you for inviting us. What we're going to talk about today is the partnership that we've developed between the Health Sciences Center, the mission that we work with in Nicaragua, as well as the Ministry of Health in Jinotega. And where we work is, there's the Department of Jinotega, which is like a state, and then we work in the city of Jinotega. So it's Jinotega, Nicaragua. So that gives you some perspective of the region that we work in. And we certainly go out into rural communities around the city of Jinotega, so we work in a lot of different regions, but that's where we're based, is really in that area. We're going to talk about the Women's Health Initiative that's been implemented, some HPV and cervical cancer statistics, the core global health competencies which guide our practice when we are working in Nicaragua. And then Amy's going to spend some time talking about the processes that we use in the Women's Health Initiative, including visual inspection of the cervix with acetic acid, or the VAI process, Pap screening, and cryotherapy. So that's what we're going to focus on. Before we get started, I wanted to just share a story to kind of put into perspective what we do in Nicaragua. So I wanted to tell you the story of Maria. Maria, in April of 2013, was diagnosed with cancer. She had just turned 44 a couple of months before, and she was devastated that she had received that diagnosis. She thought, I'm too young, this can't be happening. The doctor told her it was cervical cancer, and it was the final stages of cervical cancer. And so as he was talking to her and explaining the diagnosis, she was thinking about what could she have done differently, what could have changed her outcome. And she reflected and realized that she had not had any health care, preventive care, physician visit, anything for the last 6 years. And looking back, how that might have made a difference for her. And she said, you know, the things that kept her from going were, if they went to the clinic, the wait was hours long. The distance was way too far. They had to walk days to get to the clinic where they might receive care. And there was never enough time in the day. They had so much that they were doing, whether it was working in the coffee fields or whatever was going on. There just wasn't enough time. But the end result is in December of 2013, she passed away. So 8 months after her initial diagnosis, she did pass away. I think sadly, Maria's story is all too familiar in Nicaragua. In the country of Nicaragua, 1 woman each day dies of cervical cancer. And really the rate is a little bit higher than that. But if you think that's huge, that's a big deal. And I think the biggest tragedy in all of that is the fact that cervical cancer is one of the most preventable cancers that there is. So it shouldn't happen. So Maria's story really, I think, puts into perspective the work that Amy and I do when we go to Nicaragua and why we think it's so important to work on the initiative. We've been very fortunate at the Health Sciences Center to have support from our administration, particularly from our president, Dr. Mitchell. Ted Mitchell has really put a focus at the Health Sciences Center on global health and interprofessional education. In fact, he traveled with his wife to Nicaragua, and they went to the cities where we work, and they stayed at the mission where we work and where we sleep. And he was instrumental in developing the affiliation agreement with the entities there in Nicaragua that we work with. So we have a formal relationship and a formal agreement that really facilitates the work that we do there. The global health opportunities for our students really began with Dr. Patty Patterson from the School of Medicine several years ago. And in 2012, she invited Amy and I to go along on a trip in the summer with the medical students, and we took 1 nursing student. And so it was a small step towards interprofessional education. But we had a great experience. The student had a great experience. The medical students had a great experience. And from there, it's kind of evolved into what it is today. And we go basically into Nicaragua. We take at least 4 trips a year, and we really try to take interprofessional trips and focus on continuity of care. Women's health is our focus, but there's other groups that go that do different things too. But we always try to build in the continuity of care and really focus on sustainability. We want to help them be able to continue the work that we start, not just go and work and leave, but help them be able to follow up there in Nicaragua. So we spend some time training their nurses and their healthcare providers in addition to doing the clinics and things that we do. The picture on this slide is our most diverse group, which is why I put it up there. This is from our January 2014 group. And we had representatives from the schools of allied health, medicine, pharmacy, and nursing. And I think one of the cool things, even just within nursing, is the variety of nurses that we had there. We had traditional BSN students in second degree who are both pre-licensure, so they're not licensed as nurses. We had RN to BSN students. We had graduate students from both the education and nurse practitioner tracks, and then we had DNP students. And the video that we're going to show you at the end is this group, and they're talking about their experiences in Nicaragua, but also working together as a team and figuring out that interprofessional piece. And it's really pretty cool. We've been very blessed. That affiliation agreement that I mentioned really solidified the partnership between the mission, the Ministry of Health, and the Health Sciences Center. And really, we work very closely hand in hand, but our functions are very different. But it takes all of us working together to make this work. The mission really does all the logistics of our trip for us. They take care of all of our planning in country. So as soon as we get there, they meet us at the airport and they take care of us until the day they take us back to the airport. So as faculty taking students, that means a lot to us. The safety of our students and ourselves is certainly very important to us. So they take care of our travel, they take care of our lodging, they take care of our meals, they hire our translators, and they do all of that. They do the networking and groundwork, the legwork to connect with the Ministry of Health. And the Ministry of Health then chooses the sites that we go. So if we're going to do 4 clinics and focus on women's health, the Ministry of Health has been instrumental in choosing those sites. If we're going to teach the nurses or the community health workers from the hospital, again, the Ministry of Health has been instrumental. So we don't do anything that they're not asking us to do. It's not our agenda. It's theirs, and we're supporting it. So that's huge. They also keep us on target with policies and procedures. You know, evidence-based practice is so important, and we really focus on that and teach that to our students. When we're in Nicaragua, there's some variations of what we can do based on the resources we have available. But they have policies and they have procedures, and we have to be aware of them. And Amy's going to talk about some of those related to the VIA process and PAP screenings and the cryotherapy. So we work together to be sure that we're doing what they want to be, want us to do. We want to be respectful of their culture, and that helps us do that. And then I've already mentioned how supportive the Health Sciences Center is to us. From our deans to the president of the institution, they support us financially to travel. They give us time. We work while we're there, but we don't have to take vacation time. We know at some institutions and some schools, the faculty that travel do have to take vacation time, and we don't. So we're very blessed in that. We also have an Office of Global Health that provides lots of resources for us. They often send a representative on the trip with us, and they help us take care of a lot of the just checking the supplies and inventory and all of those kinds of things. But they also have provided scholarships for our students to be able to go. They can also provide funding for faculty that don't have funding, and they've bought a lot of our equipment. They've bought a cryo gun and some other things that we've used. So we are beyond blessed when it comes to this partnership. I think when you look at the statistics, it really shows the importance of the Women's Health Initiative in Nicaragua. Worldwide, cervical cancer is the second most common female non-skin related cancer. And worldwide, there are 500,000 cases a year, and half of those individuals don't make it. That's alarming. That's really alarming for a cancer that's so preventable. It shouldn't be. Screening programs that are based on cytology can change this. They can reduce the incidence and mortality rates by 80 to 90%. Screening programs that are not cytology based, that are screening programs maybe without the PAP capabilities and other things, those still have the potential to reduce it by 2/3. So just education, preventive practices, not even the cytology-based stuff can make a difference. So it's a lot of education. And so that's what we really, really try to do, educating the healthcare workers and educating the population as well. 13% of cases worldwide and 11% of cases that end in death worldwide of cervical cancer occur in Latin America and the Caribbean area. The highest mortality rate in that region is in Nicaragua, with 20.6 deaths per 100,000 a year. Again, that's huge. They estimate, well, let me back up. On the population, there's 2.1 million women in Nicaragua who are at risk of developing cervical cancer. So that many women age 15 or above. And of those, they estimate 934 cases of cervical cancer will be diagnosed each year, and 424 of those will result in death. I think it's interesting also if you look at what's causing the cervical cancer, the strain, the HPV, human papillomavirus strains that are causing the cancers in Nicaragua. Almost 66% are HPV strains 16 and 18. Now, I don't know how familiar you are with the vaccines that have been developed for HPV, but they're effective for those strains. But in Nicaragua, there is no HPV vaccine program. And we find it real interesting, and we've talked a lot about why there are programs available for underserved or low-resource communities or countries to receive free vaccines or a lot of assistance with vaccines, but Nicaragua doesn't qualify. And I don't know all the reasons. I don't know that we've been able to find out all of the reasons why, especially that they don't qualify. We think it's related to the fact that they don't have a cancer registry, and they're not sure how accurate all of their reporting is. They actually think it's pretty underreported, which is scary when you look at the numbers. It's already so high. But that's something that, as a group at the Health Sciences Center, our global health team, our steering task force, is really looking at what can we do about this? Is there something we can do to help this vaccine program develop? When we talk about the types of HPV, there's actually more than 150 different strains of HPV. I didn't realize there were so many. That was something new to me when I started looking at this. 40 of the strains have the potential to cause precancerous lesions or cancer. So there's a lot of variability. When you look at the Gardasil, these two right here, vaccines over here, they are effective for those strains. So one of them is quadrivalent. It'll affect those 4 strains, the Gardasil, and the other one is effective for the bottom 2 strains. They're not effective for any of the other strains. But if you consider what we talked about in Nicaragua, there's potential for success here. If you look at the cervical cancer lesions, 52%, almost 53% are from the HPV strain 16, and then you can look at 5.3 from HPV strain 18. So there's potential here to make a huge difference in Nicaragua. So that's a huge focus looking forward. We're looking at how we can affect that change. We haven't been able to make a difference yet, but we're looking at that. As far as the difference between precancerous lesions and cervical cancer lesions, basically the low-grade lesions are on the surface only. It's changes in the cells, atypical cell structures, just on the surface of the cervix. When you move to high grade, the changes are more. Instead of being, I forgot the word, I'm blank. Oh, dysplasia. Sorry. It's mild dysplasia for the low grade, and then it's moderate to severe dysplasia on the high grade. And so those high grade ones then can become more invasive and become cervical cancer. So it's real important to be able to do the vaccines or do preventive strategies to prevent us from ever getting to any of these on the screen. It's just a scary place to be.
Oh, thank you. I want to echo what Laura said about, thank you all very much for having us here. This is really exciting to be here. I think the excitement is, I was in a meeting this morning and we talked about how exciting it is to actually make a difference. And so some of the things that we do with our students is, one thing, we always have pre-trip meetings and we educate the students. We don't go on a trip unless the students have an idea of what the population, the disease process. We go always with a goal to educate the population in Nicaragua. And some of the things that we look at is, we look at what is the burden of disease. And so our students are educated before they go. And I've got to tell you, I was listening to a program from Unite for Sight yesterday, and one of the things that they talked about is, you know, when you drop in and you do these week trips, is it healthy, is it unhealthy? And I think one of the big things that we do is that we make sure that we're always building on each other. Even though we may be going for 1 to 2 weeks throughout the year, every trip that we do, we always build on each other. Dr. Patterson leads a couple of trips. Laura and I lead a couple of trips, and then we have a couple of other nurse practitioners, and they lead a couple of trips. Some of the things that we have to look at is, how does this affect this population? Cervical cancer, it's a huge thing when you have a mom all of a sudden who has cervical cancer and they are dying. that leaves that's a huge impact on the family, on the resources, on taking care of kids when, especially in so many of these families when there's not a dad around also. And looking at the type of health care. Some of the things that the students look up, and they have to present to each other during these pre-meetings, is what kind of health care do they have? And you know something, it's amazing. I know a lot of y'all have gone on global health trips. When Americans step on the ground, they're looking for you because of the education that you have. But one of the big things that we really strive to do is to educate everyone that we come into contact. We educate the community health workers, the rural community health workers, the nurses, the physicians, about the things that we know and that we do. And I'll talk a little bit more about that. And then the human rights. You never go for yourself, but you're always going for somebody else. And I hope our goal is, and I think this is for everybody, is eventually they won't need us. You know, that's what you want. It's not about you, but it's when you go and that population no longer needs what you have because they are so far advanced. So when we look at the screenings, when we look at PAP screenings, their guidelines are a little bit different. And I'll tell you, in the U.S., I work in women's health. I work at Grace Clinic, and that's what I do now is. And our guidelines are about to change in the U.S. We're about to start just testing for HPV instead of doing Pap smears. Pap smears are about to become elite, or not elite, but yeah, obsolete. Thank you for that word. Can you delete that from this? Their policies are a little bit different. They start doing Pap smears at the age of 25, and that's in their guidelines, unless the patient's high at risk. When we very first talked with the Minister of Health, and we have this collaboration and affiliation agreement with the Minister of Health and the schools, with everybody up there. And so when we very first talked to him, I gotta tell you, the data that we have, we don't know how accurate it is, because when you start getting out into the areas like Hinnataga and then out into those rural areas, you really don't know how much is reported. So probably the information is not, it's closer to the Managua area. So it's probably worse. And what the Minister of Health told us, he said, you know, our women are dying in their 20s of cervical cancer. And this is one of their priorities. And like Laura said, when we went on their agenda. What do you need? And we went to the Minister of Health and said, what's your priority? What can we do? And he said, we need to do something about cervical cancer because our people are dying. And so, so we started researching what are third world countries doing. And so we started looking at VIA and cryotherapy, and it was such a wonderful option. But they still want to do Pap smears. They're just now getting into Pap smears. The majority of the times when we go, women will come in and they're 30 and 40 and they have never ever had a Pap smear. And that's when you get the 40-year-old and something's a little bit odd going on. Well, they've already got stage 4 cancer and it's too late. So talking women into coming in for a gynecological exam is pretty amazing. But they do come, and you know, sometimes they line up for hours and hours to come in for a Pap smear. The method is a little bit different. I about died. I asked one of the nurses from the clinic from Mission Para Christi, show us how you do your Pap smears before we ever came back and made this plan. And so she took 2 Q-tips and she did the endocervical. She put it on the slide, rolled it on the slide. And she did the exocervical with a different Q-tip, rolled it on the slide, took the slide, folded it up on a piece of paper. And they rubber band all of the slides together and they send them off to Managua. So many of the women, if a woman had had a Pap smear, they never knew what the results were. They were backlogged for about a year. Now there's nothing covering that slide. They do fix it and we do take a fixative, but if that slide's sitting in Managua for a year, chances of getting that information back and it meaning anything is there's very little chance of that happening. So it's, Pap smears are very accurate if they're done correctly and they're read within a certain amount of time. But for Nicaragua, they're not very accurate. And one of the biggest thing is they never get the results back. People in Nicaragua don't have addresses. The mission that we stay at is, and I never remember exactly, it's half a mile from the gas station, or half a block from the gas station. Half a mile, isn't it? Something like that. That's the address. So when you're out up the mountain or, over across the mountain, they really don't have addresses, and people have the same name. They don't get the results. It's very, very rare that they get a result. Their access to care, like any third world country, is very, very limited unless they're actually sitting in the clinic. And then the follow-up, and you had an abnormal pap smear one year, we need you to come back next year. It's very limited in actually collecting that data. And that's something that we're really working with. We're working with the Minister of Health, and we're working with the whole program to start really giving records to the patient. But getting pap smear results is just kind of crazy. So we started doing visual inspection with acetic acid, and I was very blessed that I got to go to Guatemala with a nurse practitioner out of UTMB, and learned how to do VIA, and it's really, really easy. I can teach all of you in 5 minutes. You take vinegar, it's 5% acetic acid, but it's really just vinegar, and you swap it on the cervix, and when you were so smart doing that pointer, okay, you get this little, you get this little white area that pops up. It's a pseudoacid white area, and that's positive. And when you do this over and over and over, you get really used to seeing these. Some of them are a little bit sketchy, some of them aren't, but you see it. It's right then. It happens within a minute. It pops up. You know what it is. And you get really comfortable with seeing this. And so it's immediate. And when we do this, we can turn right around and we can do cryotherapy. And so we're saving lives by doing this. Not only that, but we teach their people how to do this too. So now their community health workers are doing it. And that was a great thing, and I think we have a slide on this in a few minutes, but actually working along beside their nurses. We taught 32 of their nurses how to do VIA, and so they're out doing it. So now you all know how to do VIA, so it's really, really very easy. You put the vinegar on a Q-tip and you put it on the cervix. It's immediate. The disadvantage, it's about 41 to, if you look in the literature, it's 41 to 91% accuracy. Because I can look at a lot of cervixes and go, it's kind of questionable. Well, they got that white area, but it's not the well-defined border. And that's the big thing about it is, you've really got to find that well-defined border. If you do cryo on somebody that's not positive, it's really not going to hurt them. I mean, you're freezing the top layer of the cervix off. We do have to be very careful. One of the things about doing cryo is you don't want to do it on somebody who's pregnant, but it's really not going to make a huge difference if you accidentally cryo somebody. And it's very effective in treating cervical cancer. This is what we used to do in the U.S. before we started doing LEAPs, and it's very easy. You have a little cryo gun, and it's I think of it as putting a pencil into a pencil sharpener. You stick it in, you cryo for 3 minutes, you're off for 5, let them rest, and cryo for 3 more minutes. It's not painful. They may cramp just a little bit. They have a discharge for several weeks after, but it's really, I don't know, have y'all ever froze anything off of had a wart frozen off or anything like that? But it doesn't hurt near that much. So the disadvantage is a little bit, as far as the how accurate we read them. And one of the things that we're looking at, I told Laura, I said we had a lot of meetings today, and one of the things that we're looking at is taking a pathologist and actually seeing how accurate we are on doing this. So I'm very excited. I've had a lot to talk about, Laura. So the follow-up, trying to get the patients back again. We want them to come back. We want to recheck them. We want to we want to make sure we get a pap smear, but we want to check them for VIA later. And it does make the cervix look a little bit different. It does have a little bit of a scarring effect. So cryotherapy, the policies are, it's really interesting looking at the policies. You take their blood, you want to make sure you have their blood pressure. That's one of their policies. They do have a little bit of a discharge, but it's not a really big discharge, but they want to make sure that they're not, that they don't have a low blood pressure, because they're very worried about them having too much blood loss. You really don't have blood loss, they just have a discharge. I just talked about the method. It's like putting the pencil into the pencil sharpener. I know but that's really basically what it is. There are particular things. If you've ever done cryotherapy, you've got to be really careful. You want to make sure that your tip's on good. If it's not, then you can shoot it through the cervix. That would cause all sorts of problems, but because there's a lot of pressure. Yeah, that's the look you should have. You don't want to shoot the cryo tip through a cervix. But other than that, it's very minimal problems with it, very minimal pain. The disadvantage, it's not as good as, it's not as effective as doing like a LEAP procedure. But otherwise, there's a lot of advantage to doing this. When we go, even with, we try to use the plastic speculums, but anything in Nicaragua, just disinfecting equipment, the disinfectant, we've just got to be very careful about that. I actually take stuff from our clinic, and so for every trip I have our disinfectant, but trying to find things there is a little bit different. And again, the disadvantages are the database tracking. They don't have records there. They have very few records, I should say. If some of their little clinics may have some records on patients, but very, very limited in their
paper records.
Yeah, in their paper records. And that's something that we're working on, is actually having creating a computer base for records. So, so our goals. That's Lauren. That's our focus. We have several other different things that we do, but our focus was doing women's health, or it is doing women's health. We'll end up, we'll take so many trips throughout the year, and not only our group, but there are also other groups. Like when Dr. Patterson's group goes, they do cryo also. When I went and learned how to do this, and I taught all the nurse practitioners. I've taught the nurses. Went and talked to Dr. Patterson, and usually she takes a women's health somebody with her to do it, but we're all doing it now. So when we went in January, so that's part of our thing, is to be sustainable. When we went in January, we did train 32 healthcare workers, and I got to tell you, it's the most exciting thing to see pictures of our nurses working right along beside their nurses. It's really, really, it's just a really good thing. We screened 93 women in January. We screened close to 60 when we went a couple of months ago. And the first time we had 9 who were positive. We treated 5 with cryotherapy on this last trip. So now the thing is, we want to be able to follow up with these women. That's the difficult part of this. So some of our challenges, I want to point out, these are stirrups right here. They're gynecological stirrups down in the corner, and these were made by Rice University. We've been able to collaborate with other people. These were made by Rice, and when I went into Guatemala, they were working with a nurse practitioner there, and they made 5 of these for us. They're just wooden little pieces of wood that fold up. They're portable, and that was one of their projects. But trying to keep up with with things like that, and with the speculums and all of the different supplies that we take down there. When we go and we take a cryo gun, somebody's hanging on to it all the time. And it's not that people are dishonest in Nicaragua, but if you leave something around and it's really, really needed, which a cryo gun is, things tend to venture off. So that's trying to keep up with those supplies is a huge thing for us. Probably our biggest issue are the patient records and collecting the data, and that's a big project that we're working on now. They have a brand new Minister of Health. We were doing really well with the old Minister of Health. He was really used to us. We could sit down and visit with him. He'd say, "This is what I want you to do. Yes, go do this." They have a brand new Minister of Health, so we're having to break in a brand new Minister of Health. And he's really coming around, but it just means that we have to do a lot of visiting with him. Our resources, being able to get things once we get down there. When we go, we always send a list of everything we take, that we're taking. Like we're taking a cryo gun, we're taking ibuprofen, we're taking antibiotics. A lot of things we order from there, but if we're going down there, sometimes it's difficult to get resources once we get down there. So, and then the resources for just doing things like Pap smears. And sometimes we get down there and supplies that we have there may have gone to another clinic. And then IRB approval, that's always a challenge, I think. I think as much as anything, the time to do things like that. And then our time and our expense. We're really blessed, like Laura said. We have a very supportive dean and the president of the university. They're so supportive of us, and we do have funds, but we always spend money on supplies and extra things. So I don't know how much we've spent. I try not to ask my husband, or he's very nice not to ask me about any of it anymore, but it is a lot of time. We work all day long. We may get up at 5 and leave by 6. We may not get back till 6 or 7. Then we work with the students that evening to prepare for the next day, to get the supplies, because we may be going to 4 different areas. We did that in September. We went 4 different areas every single day, and that takes a lot of faculty to be able to do that. And it's so. And then we have to stop and do our teaching after that. So there are a lot of times Laura and I are in the little area of working at 1 o'clock in the morning. So anyway, some of our research opportunities is the interprofessional education. Laura and I did this the very first time we went. We went back in March 2013 with our first group, and it was a survey of the students of how they felt about the trip. What were their reactions of the trip? Was it a positive outcome? And it was. Overall, the students let us know that working with other interprofessional students was a very positive outcome. They had higher ratings on that survey on the post-survey than they did the pre-survey. So we know that it was very positive. Some of the things that we'll look at, and we've also done some research on the access to care, and some of the things that we will start looking at is the VIA effective? What are we seeing in cervical cancer? And really and truly, what are the cervical cancer rates? And then our collaboration. We have been able to collaborate with Rice. We've collaborated with Harding University on one of the trips. They had a physical therapy group. If you ever get to go with other groups, physical therapy is a great one, because when at night when you're just so tense and they're going, let me work on your back. I'm just going to say physical therapy is a great group to be there. Sustainability is one of our goals, and eventually for us to be able to step back and say, y'all don't need us anymore. We'll come for vacation. We'll come to visit. The policies and procedures, they need some changes in some of their policies. And our policies and procedures, making sure that we're all on the same page every time we go. The data collection, the charting, these are things that we're working on right now. And collaboration with schools for education, not only our schools at Texas Tech, but their schools. Our School of Medicine works with their School of Medicine that's out of Leon, Nicaragua. And I'm so excited because we're going to get to start working with the School of Nursing that's in Hinatega, and I'm hoping that we'll have the opportunity to do that in our trip. We're going back in March, and they have a lot of needs in their School of Nursing, and so I'm really excited to get to work with them. August, we're planning on bringing all of those schools together in Hinatega, the School of Medicine, the School of Nursing. We've got a lot to talk about. So that's a really exciting thing to work interprofessionally even within their schools. And then the use of technology. We do have some of the technology to be able to link to Nicaragua now. And that's our head IT guy went up, and that's some of the stuff that we're looking at now, is to be able to help, especially the medical students, because they'll go up for a month or two, and to be able for them to do telehealth from Nicaragua. And so those are some of the things that that we're looking at. And then resource sharing, being able to be able to share the things that we're doing now with other people. And I'm excited to be here, I've got to tell you, because I know y'all have a great program here, and I'm really excited to visit with y'all. As a matter of fact, I'm supposed to be visiting with Cindy. Oh, there you are. Cindy, you were over here earlier. Cindy, very soon. And I just think that's a really important thing. So we have a video, and this is what our students, this was in January, what they thought. We just wanted to show this to you. It's not very long, it's about 5 minutes.
Another thing is that I'm an education major, and I didn't expect to do what I did.
As a family nurse practitioner, going back through to get my doctorate
in the AED program, and I'm in Allied Health. Because I was coming into this trip intimidated because I was an undergrad and I don't know a lot of stuff.
I just wanted to say, in my career, I've never really had the opportunity to work with nurses as closely. My experience has been mostly in rehab, so it's been primarily with occupational and physical therapists.
It was really good to see all the interprofessional work with the nurses, the School of Allied Health, the fourth-year medical student that came with us. Everyone really worked together.
And so I hope we get to do more interprofessional mission trips, because I think this is something that Tech really has a great base to expand on, and I think this was a really cool first kind of experience to really let me plug in with y'all. So. There's been a really big change in focus. As we go through our BSN program, our NP program, there's a lot of focus on the patient in front of us, the patient we touch. There are community assessments, and we do things like that. But throughout the DNP program, there's been a great focus on community. How can you change the health of the person in front of you by changing the environment around them?
But I knew with the Women's Health Initiative, this was an opportunity, and a very timely opportunity.
We have saved lives. When we leave here, the nurses that we taught to do those VIAs, they are going to treat women on the spot so that they don't progress to cervical cancer. That's what we did this week. When we walk away, just like Dr. Hina said earlier, we planted that seed. What we did today is going to stay in this community, and it's going to make a difference. Children are going to have their mothers.
But it was a big compliment, because it's hard for us, I think, when coming in to, their clinics and their country, and to be able to communicate with them in a way so that they feel like we're working together and that we're not teaching them something, we're all learning something together. I thought that was a really big compliment, that they gave us that trust and to allow us to do that with them.
Something that I was extremely impressed with through these last few days was no matter how long they waited in line to see a student, they were extremely grateful. They completely trusted us, and they completely were gracious and accepting of what we had to show them.
Experiences and everything that I have learned, I think
I think I have gained so many friends.
It's not about being selfish anymore. You've come to do exactly what you've trained to do.
To Nicaragua will change a lot of my practices at home for many reasons. We were a very hands-on, very group-oriented team that helped each other out.
I'm just so thankful for the resources that we have and that we were able to share with them, you know, our knowledge, you know, our compassion, just everything in general. So I just know that we have a lot to be thankful for.
And when I came here, I remembered why I became a nurse, to help people. And I feel like they really helped me instead of the other way around.
One thing that isn't reflected there that I think stands out in my mind from our participation and from the partnership, from going back to the same place again and again and working with them, is the trust that we've developed with their group. And there's a lot of women that work at the mission. I can't remember how many employees the mission has, but it's 70. And their women did not have dental care, did not have women's health screenings. And as we've been going back again and again, they've had dental care and they've had women's health screenings. In fact, they wanted us to do them, which was pretty cool to us. That was really exciting. They didn't want anyone else to do it. They waited for us to come back and for us to do it. So I think that speaks volumes of the partnership and the successes that we've had. So thank you for letting us have the opportunity to share our experience with you guys. Are there any questions that we can answer?
You should tell them what this means, what this is.
These were cervical osses, where we went around and practiced doing the VIA procedure. And so everyone that was in the training, our nurses and theirs, practiced doing some VIA on their cervical osses. That's why there was so much excitement. We were having fun. Any questions? Okay.
It's always exciting to see what people are doing around the world because there are so many things that need to be done. And I think probably one of the things, probably the first time you went might have been, it's overwhelming because you see the need and you're just overwhelmed with, I mean, where do you start? Because we have knowledge and they need it. And so you just almost feel pulled in so many directions. I love that y'all focused on one thing because so many times I have a lifetime of doing these kind of things. This is, my family started me out early. And one of the things that happens so many times is we have good intentions, really good intentions to go and make changes and to Americanize the world because we have good things here. Even though we complain and whine and whatever, but what we have is so much better than the rest of the world. And so we like to go places and fix it. We want to go and give them shoes because they don't have shoes. Or we want to go and give them clothes because they don't have clothes. But sometimes we're actually causing more problems than we're helping. Because we go and give clothes, then the local seamstress is out of a job. We provide shoes, and the shoemaker no longer has people buying shoes. We give them shoes, and the others that didn't get shoes will beat them up to get the shoes. But we were doing good, we thought. And it was our intention to help, but we don't always help. And so it's really important that we have a good focus. And we understand that we need to go in and help collaboratively, help them to help themselves. Because we can't fix everything. And I know America's tried really hard to fix everything around the world, and we're not great fixers, but we want to be, but we're not the best at doing that. And I love what y'all done. I love the whole premise of how you've incorporated other allied health, physical therapy, pharmacy. That's what's needed. We can't isolate and everybody hit somewhere in the world and do little bits and pieces and then walk away. Because when you do that, you've left them with the little bits and pieces, and oh yeah, they came, but they left because somewhere else was a great place to go next, you know. So this is great. I'm really excited for what y'all are doing. I think Maria's story is a story that could be spoken of around the world. One of the things that has happened, and we know in populations here in the U.S., that if you take a mother out of the family, you have disabled that family. That family is no longer able to function as a whole because the mother provides something that no one else can provide. And so when those mothers are dying at that rate, the family is left devastated. Not only the family, but it devastates the community when you take mom out, because the mother is the caregiver for that community. And unfortunately, in any country, but especially in Latin American countries, the mother will disregard her own care in order to provide care for her children and her spouse or her distant relatives even, because that's the most important thing to her. And so it's kind of that double-edged sword. She's the caregiver, but she's unwilling to get care for herself in order to stay alive, to care for her family. And so it's really sad what happens in the world, but I think that sometimes we can make it worse. We can go and we can take our fabulous machinery and equipment and fly into a country and we can fix a few things, run a few tests, and we can leave. And then what? We can go and deworm Peru. We can, in a 10-day period, we can see 10,000 people. We can give them all worm medicine. We can cure worms in Peru. 3 months later, we're gone. Worms are back. So what did we really do? Did it really help? Maybe we just shocked their system and they have more illness because we just took the worms out that they're used to. But the problem is that we've got to think what's happening long term. If I'm throwing medicine at them, which they don't know how to take, you give them a bag of iron pills and say, take these, don't let the kids have them. They look cool, they're from America, why wouldn't they have them? We walk away and we have no idea what happened to them. So being able to teach the healthcare workers there, teach the nurses, collaborate with them, is a perfect model. It's the same model we used when we went to Kenya, same model whenever Cindy took a group to Honduras just a few weeks ago. You go in and you work with those people. You don't become the American savior flying the big flag, bringing our good stuff. In America, we have this. When I took a group to Kenya a couple of years ago, one of the things when we were talking about health issues in Kenya, in the area we were going to, the students' first response was, oh, we need to take this because they need it. Gloves, non-sterile gloves. We can ask around the hospitals and doctors and we can take in suitcases of gloves because the nurses don't use gloves in the care of patients. They don't have them. It's an expense they don't have. They can't afford. Having lived through many of these type trips, my question to them was, and what happens when we're gone? And the gloves are gone. Then what happens? Then they go back to doing the care without gloves. So it's really important for us to understand that we can't always make it the way we do practice here. So not having all of the equipment and all the fancy stuff that we do here, not having leak procedures, although it'd be grand if they did, they don't. but looking at alternative ways to be able to treat. Not having an address is not something that we would even understand. And we're probably one of the, well, America, Europe, Canada, we have addresses. The rest of the world, not so much. Go down the street, when you see the barking dog, turn left, then go to the house that has the toilet sitting in the front. This is if you're in New Mexico. Toilet sitting in the front yard. And that's directions to get someplace. And so we don't have that. They don't have mailboxes. They don't have a way of contacting them. So being able to try to fix what you can then, that's the way to do it. Because if all you're going to do is test and then try to get back with them, have you done any good? Did it benefit you any to know that you had cancer when nothing could be done about it? Probably not. So it's really important that when we think about these kind of trips, we think about what's happening in the big picture. Is it sustainable? Can we go back? If you can't, think really carefully about what you're going to introduce. Because it may be something that's not going to help and actually could cause harm. I really love the idea of working with the community health workers. We found the same model used in Kenya. They're in Kenya, now I don't know about in Nicaragua, but in Kenya, they are not medical people. They're like the promotoras that you would see in Mexico. They're community people that have influence, that have a desire to help people, and probably if they had the ability and the opportunity, they would probably be doctors and nurses. But they don't have the education to do that. But these are the people in the community, they're go-to people. And that's who we would teach in Kenya, is the community health workers. I think the world is hooked onto something that's really good in community health workers. There's a lot that they can do. They have a lot of influence in their own communities. And so they're the ones that need to be the ones to pull those people in order to get treatment and to get care. Yes, we can draw a crowd because we're white and we're Americans and we're different. But they're the ones that will sustain what's happening in the long term, not us. We can't. We've all got jobs here. When I was in Kenya last, one of the things that at one of the hospitals we would work in, we did all their continuing education for the nurses because they had no other opportunities. And one of the things the hospital administrator said is, can you come and teach in our school of nursing if we make one? Because they needed nurses. And I said, I would love to do that, but realistically it's not going to happen. I have a job. I have responsibilities and I can't do that. But you can train nurses and we would be happy to train them further when we come. But we can't run your school for you. And we can't do it from America. It's just not possible. But they see what we have and they want it. But in their own way, they can do a lot. We just have to help them get there. One of the things that I always think of, because I do come from a background of service and taking care of others, is I always think about the parable of the faithful servant in Luke. And in that parable, they talk about much being required for those that have a lot. And I know in that I'm taking it out of context because it's talking about spiritual gifts. But when we look at what we do and the physical blessings that we have and the education that we have, I think we do have a responsibility to the world that all of us as nurses have a responsibility to those that are less fortunate, whether it's in Nicaragua, it's in Kenya, it's in Peru, or it's in Lubbock, Texas, in the homeless populations, or down the street from you. We have a responsibility because we have been blessed. Why were you born here and not there? That's a question you should ask because you have the ability to make a difference. You need to be making a difference because you were blessed to be here. John F. Kennedy used that passage, although he never did give credit to the Bible as having that was where it came. He said when he was trying to just motivate and rally America in the 1960s, well, late 50s and 60s, to service, he used that passage and said, we've had a lot given to us, we need to give to others. And in an unprecedented rate, Americans donated time, money, and themselves to join the Peace Corps, to join whatever services they could to help other people. And I think it started almost a revolution in this country during that time of service. We've kind of come away from it, but we still have pockets of people, and nurses are right there with it. They're in that pocket of wanting to be service to the community. And I think that it's important for us to always remember what we have and what other people have. That's one of the reasons we love, Joanne and Cindy and Bev and I, we take trips. We'll drag students anywhere around the world, won't we? And we do. And they love it. But one of the things we love is watching them change. Because when they go and they come back, they realize how blessed we are. It's a little harder to complain about what we've got when you've seen what they don't have. And so it's really important for us to always be willing to give back. In any situation, we've got to be willing, because we have been blessed abundantly. And I think this project is fabulous. We love Patty Patterson. She's on our board, so she's part of us. And so we've heard of her stories about Nicaragua for many years. And I think this project is fabulous. And I kudos to y'all for sustaining it and continuing it. And you know, it takes a lot of people to do that. It takes a lot of effort. So we're really happy for what y'all are doing. I can't wait to hear about outcomes of long term, what would happen, and the rates decreasing for these women of death. So I think it's awesome. Thank you so much. We're glad you're here. Glad we got to introduce you to Lubbock Christian. This is right up our alley. We love doing this stuff. So thank you so much. Thank you to everyone for coming. If you have any questions, please direct them to the experts in the room. And thank you for coming.